some, not all of these slides, because we're on the time limit. But you have access to these, so. All right, so therapeutic communication, I'm not gonna read this to you, but do remember, there are some tips to therapeutic communication. Remember, if it's why, it's not the answer. We're not gonna ask why, because that is not going to be helpful, right? If it is a quick fix, it's not gonna be your answer. We want open-ended questions. Tell me more. How does that make you feel, right? We're not gonna give advice to our patients, because that's their job to come to. We're not gonna tell them what to do. All right. I need to tell you something, but you have to promise not to tell anyone else. Can we do that?
Sure.
No. So we do protect HIPAA, but remember that does not include our treatment team, so we will have to disclose that information to the team. Other reasons that we would actually break HIPAA would be if there is a threat to someone else, so there's a duty to warn, then we're gonna have to break HIPAA so that we can warn that person. All right, let's talk about Maya, who's a 21-year-old female. She's brought to the emergency department by her roommate who found her giving away her personal belongings. What's that a big red flag for? Suicide. Reports 2 months of worsening insomnia, 15-pound weight loss, and anhedonia, which we said earlier is loss of pleasure. Failed 2 college classes this semester, so we've got some situational stressors. Everyone would be better off without me burdening them. That's hopelessness. All right, currently she has a flatted, blunted affect. She has slow, soft speech. She has poor eye contact, and her hygiene is disheveled. All right, what is our priority assessment for Maya?
A suicide screening?
We need to do a suicide screening. Yes.
Including asking if she has a plan.
Yes. So your patient safety screener or your Columbia suicide screener are both really good standardized assessment tools, and they're gonna tell you, ask these questions exactly as they say. So we're not gonna mince words, we're not gonna say, hey, are you thinking about it, maybe? It's very direct assessment, okay? All right, what are 2 risk factors from her history?
She failed her classes.
Okay, we've got situational stressors.
She's lost 15 pounds.
Okay, we've got some signs and symptoms. That top one, giving away her personal belongings, that's a big one. What is a potential protective factor? What are protective factors?
Someone cared enough about her to bring her here.
Right, so protective factors would be things that the patient
Like
has
family
going
and
for
friends.
them. Right, like a close, significant relationship, okay? Or future thinking would be a protective factor. Something to live for is what we're looking for, okay? And then immediate action. Maya asked to go to the bathroom alone immediately after triage. What do we say?
You can go with her.
That's right. She's now one-on-one because she's a suicide risk. All right, suicide risk. I'm gonna let y'all read through that. While conducting the belongings check, you discover a small bag of unlabeled pills hidden inside Maya's sock. I just wanted to have a way out. If it gets too hard in here, please don't take them away. All right, in what order are we gonna do these things over here?
Secure the pills first.
Okay, secure the pills first.
No.
Initiate one-on-one.
Initiate one-on-one first.
Mm-hmm.
Okay.
And then secure those.
Okay, then let's secure the pills and do a complete environmental search.
Talk to the doctor.
Then let's assess Maya's immediate intent before we call the doctor, right?
Okay.
Yeah, and then what?
Call the doctor.
Then call the doctor,
Then doctor.
then document. We're always gonna assess before we call the doctor. Even if my patient doesn't have a pulse, I've assessed something before I call, right? So remember, we're always doing some kind of assessment before we call. You gotta have something to tell the physician. All right, James was brought to the police by the police after being found shouting at traffic. He's disheveled, glancing around the room, and fearful. We have darting eyes, head tilted to the side. He's mumbling to himself, don't tell them. He's guarded and suspicious. He says they planted the bugs. All right, James suddenly stops pacing and stares intensely at the wall. What is the priority action?
B. Command the.
Yes. what's going on with
She's
James?
having a manic schizophrenic.
Yes, he is psychotic, for sure. Okay, so psychotic would mean we have psychotic symptoms, that would be auditory hallucinations, that would be delusions, that would be bizarre behavior. So, I think he actually has all of those. All right, James has been admitted to the unit. He's responding to internal stimuli, looking around the room, muttering, and appears guarded. He's not slept in 3 days. He has no known prior psychiatric history. All right, medication. What are we gonna start him on?
Second gen,
Why?
because the other ones are the side effects.
Okay, they have less side effects, correct? What else?
And it's new, like he doesn't have a history.
He doesn't have a history. When I'm looking at positive and negative symptoms, second generation treat positive, negative, or both?
Better.
Both. First gen only treat positive symptoms, right? So we start with second gen. They have a better side effect profile. Patients tolerate them better. Ideally, that's where a patient's gonna be. All right, you administer the first dose, and 1 hour later, James complains of a thick tongue and his neck feels stiff. What's going on?
And, oh gosh. No. It's not part of this condition, it's the other one.
PPS.
Yes, but which symptom? It's not neuroleptic malignant syndrome yet. Not akathisia. It's acute dystonia.
Okay.
How do we treat it?
Benadryl.
Benadryl, which is diphenhydramine, or benztropine. Cogent is the name brand for that one. All right, a few days later, James becomes confused, mute, rigid, and his temp spikes to 103. What's going on now?
Now he has neuroleptic.
Now it's neuroleptic malignant syndrome. What do we do?
Dantrolene.
Dantrolene, stop the antipsychotic, and he needs to go where?
ICU.
To ICU, we need to do cooling. All right, Robert. Robert is feeling really shaky and anxious. His heart is racing. He usually has a few drinks by now. His last drink was about 12 hours ago. Daily alcohol use for 15 years. History of withdrawal seizures 2 years ago. Currently, heart rate is 118, blood pressure is 158/94. He has visible tremors. He has diaphoresis. All right, what standardized assessment tool are we gonna use right now?
Oh, CY.
This is a CY, yep. All right, Robert is hypoglycemic. The provider orders IV dextrose.
You better give us time.
That's right, we have to give thiamine. Why?
So he doesn't end up with encephalitis.
Wernicke's encephalopathy, that's correct. Given his history, what specific precautions need to be implemented in his room immediately? Seizure precautions. What do I do for seizure precautions?
Get little pads.
Pads and suction and, correct. Oxygen suction, pad rails. All right, what class of medication is the gold standard for alcohol withdrawal? Benzodiazepines. And what is my specific goal of therapy? And I'll take 2.
Seizure prevention.
Seizures and
Suicidal.
symptoms. Right,
Oh.
so it's gonna overall decrease my symptoms. It's gonna help my patient be calmer. It's gonna help my blood pressure be lower. It's gonna help the tremors calm down. It's gonna hopefully prevent seizures. Seizures would be the #1 thing that we want to prevent, but it's gonna help overall. All right, Robert, now 36 hours since his last drink, becoming increasingly agitated and confused. He has moderate tremors, beads of sweat on his forehead. He says, why are there spiders on the wall? So we have what? Visual hallucinations. Heart rate is 118, blood pressure 158/96, temp of 99.1. His CWA score is 19, which tells us he is at moderate severe withdrawal. All right, what is our priority nursing action? C, give the lorazepam. All right, might he need to be in restraints?
No.
Not yet.
If he has a seizure.
Maybe.
Right, maybe, but there's nothing up here that tells me he needs restraints, okay? So that's not the option. IV dextrose, is it a good option? Sure, is it the priority option?
No.
No. Consult social work for rehab,
You're right there.
we're not there yet, right? Appropriate, not the priority. All right. Okay, Sarah, brought to the ED by her partner, currently pacing the room, clutching her chest, heart rate is 112, respiratory rate is 28, she's hyperventilating, she has dilated pupils, she says, I'm going to die, I can't breathe.
She's getting
Right.
oxygen right now.
We've got, well, does she need oxygen?
She's well, I mean, she needs a bag.
She needs a bag, she is anxious, all right? She does say that she's clutching her chest, so what might we wanna do?
EKG.
Right, we need to rule out that this could be a heart something. What nursing response is the most appropriate? Okay, I like that. Why not A?
Because you don't know that.
Okay, you don't know that. Also, it's minimizing. Okay. Okay, why not B?
You know why?
First word is why, it's not the answer, right? Why not D?
Because that's downgrading.
Telling someone to calm down has never made them calm down. Okay, so that is not the option. I will stay with you, look at me, and take a deep breath with me. All right, I'm gonna let you guys read through this on your own. Sarah T, again. Partner brings Sarah in, states a week ago she was panicking. We saw her, she had a panic attack. Now she won't sleep. She spent $3,000 on business ideas yesterday. She says, I don't need sleep. I'm buzzing with pure energy. She's sleeping about 2 hours a night. Her speech is rapid and pressured. She's difficult to interrupt. She is wearing flamboyant makeup and provocative clothing, which is not characteristic of her. What's going on with Sarah?
She's got a bipolar manic disorder.
She is manic, yes. All right, so what could have happened is we maybe sent her home on an SSRI to treat that anxiety long-term, right? But what that did instead was it flipped us into a manic episode. So remember, females often present with their first bipolar episode as depression. And sometimes what happens is we don't know they're bipolar yet because we haven't seen mania. So we will put them on an antidepressant and then we end up flipping them into mania. So very important to monitor mood after we start patients on an antidepressant, especially if it's their first time being on one. All right, what is the priority nursing action for Sarah?
CP.
Okay, C, reduce environmental stimuli and assign a private room. Absolutely. Why not A?
It takes a couple of weeks for them to kick
Takes a
in.
couple of weeks and it's not gonna help the mania. It's gonna make it worse. How do we treat mania? We need a mood stabilizer, okay? So they could be on an antidepressant, but it would not be as monotherapy. You can't treat a bipolar patient with an antidepressant alone. They might be on an antidepressant and a mood stabilizer, especially if they're currently in a depressive episode. But we're not just gonna send them on an antidepressant. All right, sit Sarah down and logically explain why her spinning is reckless.
There's no logical thinking.
It's a great way to waste your breath, all right? Sarah cannot understand that right now. You're not gonna be able to logically rationalize with her. All right, encourage participation in group therapy to help channel her excess energy.
Group is probably in two standards.
Right, so she's probably not appropriate for group right now, but even if she was, it's not gonna be the priority. We need to reduce environmental stimuli. All right, any questions about this one? All right, change of shift report. We have Maya, 21-year-old who was admitted with major depression disorder. She's sitting in her room with the lights off. She has breakfast tray in touch, states, I'm just too tired to eat. James, who's pacing near the nurse's station, mumbling loudly at unseen others. His fists are clenched, he's yelling, shut up. Robert, who has tremors, he's diaphoretic, he's picking at the sheets, so what does he probably have going on? Tactile hallucinations. Heart rate 124, blood pressure 160 over 98, he's disoriented. All right, and Sarah, laughing loudly in the day room, tried to give her shoes to another patient, she's interrupting group therapy. Who do we see first?
Robert.
We see Robert first. Who do we see second?
James.
We see James second, right? Safety. Who do we see third?
Sarah.
Sarah, she is disrupting people on the unit. We need to go see her. All right, and then Maya gets seen last. Any questions about that? All right, this is a really good slide on delirium versus dementia versus psychosis. You'll see some stuff pop up on this on your standardized test. I'll let you read over it. There's nothing earth-breaking here, but I do like the way it lays this stuff out. All right, medications we've already talked about. More medications. All right, let's do this one. This is a medication safety challenge. So what you do is we have a list of medications here. You're going to match them up with the adverse effect and then the nursing priority. Okay, so let's start with clozapine. I'll take a minute to read through those and tell me what adverse effect do we have for clozapine?
Is it the agranulocytosis?
It's the agranulocytosis. This is the one that requires frequent blood draws to check white blood cells, and what we're really looking for is that ANC, that absolute neutrophil count. All right, what's our nursing priority?
Monitor CBC.
Monitor CBC, ANC, and report fever or sore throat. All right? Phenelzine, hypertensive crisis. Okay, why?
It's an MAO.
It's an MAOI. What's our nursing priority?
Dietary restrictions.
Dietary restrictions, yes. All right, lithium, what's our adverse effect?
Toxicity.
Toxicity, and what's our nursing priority?
Monitor level.
Monitor therapeutic levels.
Yeah, that's right.
Lamotrigine,
Stephen-Johnson syndrome.
Stephen-Johnson syndrome, yes. What's your nursing priority?
Stop med and assess skin.
Correct. And then lorazepam, respiratory depression, nursing priority would be
Flumazenil.
administer flumazenil. All right, the nurse has received change of SIP report. Which client should the nurse see first?
Anything we do.
Okay, what do we think? Client with schizophrenia reporting auditory hallucinations commanding self-harm, or a client with generalized anxiety disorder reporting a feeling of impending doom? Who wins out?
I think D is physiological.
It's B.
Yes.
It's B. Command hallucinations are a bigger safety risk. Do we need to assess D? Absolutely. But is a sense of impending doom a symptom that we would expect with generalized anxiety disorder? Yes, it is. All right, the charge nurse is making assignments for the day shift on a psychiatric unit. Which client is most appropriate to assign to the licensed practical or vocational nurse?
See.
C. Okay, remember, we don't delegate teaching assessment. P is planning, no, P is, I'll have to remember what P is. P is evaluation. That's the P. Teaching, assessment,
Careful.
that'll come back to me.
Careful.
Priority, higher priority. A client with major depressive disorder who has been withdrawn in silence suddenly approaches the nurse's station and states, "I just can't take it anymore. It's all too much." What is the nurse's priority action?
A.
A, very direct questions for assessment, right? Are you thinking about hurting yourself? Client taking haloperidol develops clinical findings suspicious for neuroleptic malignant syndrome. Which findings would the nurse expect to assess? Select Oz and apply. So would we expect A?
Yes.
Yes. Would we expect B?
Yes.
Yes.
Yes. Would we expect C?
No.
No. C is more consistent with serotonin syndrome. Would we expect D?
Yes.
Yep. And would we expect E? Yes. So everything except for C. A client diagnosed with major depressive disorder states to the nurse, "No one cares if I live or die." Which response by the nurse is best?
C.
Okay, C. Why not A?
Because you can't, that could be a,
Right, you don't know that, and it's minimizing. Okay, why not B?
it's a lie.
It says why, so we mark it out. Why not D?
Because,
Tell them what to do.
Yeah, it's telling them what to do, it's also minimizing, right? It's not validating their feelings. Client voluntarily admitted to the psychiatric unit, tells the nurse, "I'm gonna kill my ex-boyfriend as soon as I get out of here because he ruined my life." Which action should the nurse take first?
Um, D.
Anyone like anything else?
I like B too, so.
B is the answer. This is duty to warn, so remember, for duty to warn, we would need to break HIPAA and let them know. Now, is the team automatically gonna jump to warn? Probably not, depending on what my patient is admitted with. If they're psychotic and we get their psychosis better, this may not be present anymore. So we let the treatment team kind of decide how they need to handle that, but as the nurse, it's your responsibility to know that we have a duty to warn, we need to tell somebody. The nurse is providing discharge teaching for a client prescribed lithium. Which statement by the client indicates a need for further teaching?
B.
B, we don't need a low sodium diet on lithium. Client with schizophrenia states, "The TV is sending me special messages that I need to save the world." Which nursing intervention is the priority?
what are they saying?
That's not an option. Okay, C, anyone like anything else? C is correct. Okay, why not A?
Because
It's probably just gonna,
you're gonna send them into a frenzy.
You might, it doesn't address the problem. So yeah, we can turn off the television. They're still having psychotic stimuli, right? We haven't addressed it. Okay, B, why not B?
They're very.
Yeah, they've already said it. Okay, C, present reality by stating, "I don't hear any messages from the TV." Why is that appropriate? Right, you're reality orienting. Remember, with schizophrenia and acute psychosis, we always do reality orientation. We don't play along with hallucinations, all right? We don't tell them, "Yes, I hear it too." We don't argue with them and say, "No, it's not there," but we do present reality. All right, administer a PRN antipsychotic. Why not? How long does it take for antipsychotics to work? About 2 weeks. It's a couple of weeks, okay? We might see some response within that first week, but this is not gonna work immediately. You can't give the medicine and this goes away. Client admitted for alcohol detoxification has a CMAL score of 15. That's a moderate withdrawal. All right, vital signs are BP 168/98, heart rate 104. The client exhibits visual tremors and anxiety. What action should the nurse take first? Give the lorazepam, yes. Why not A? We need to assess more frequently than every 4 hours if we have escalating CWALs, okay? Encourage the client to drink fluids and rest. Is that gonna help?
Probably not.
No.
What he's drinking.
Well, that's true. Prepare the client for a stat CT. Is there a reason we need a stat CT?
Well, at this point.
No. Client who is 3 days postpartum refuses to hold her newborn and states, "I can't do this, I'm gonna hurt him." What is the priority nursing action? B, assess the client for thoughts of suicide or infanticide. Right. Questions about that? All right, that's my last question. Questions about anything? All right, if you're looking through this stuff, if you have questions come up, shoot me an email, bjones@suscc.edu. I am in your course